Good morning everyone, this is Dr. Shaima. So we continue with basal ganglia. So yesterday towards the end of the class I had briefly explained what the direct and the indirect pathway of the basal ganglia is. So I think I'll just memorize or just try to revise few things of the direct and the indirect pathway, so that we go forward with the topic with more clarity. So by now you all should be aware that the functions of the basal ganglia is basically to initiate and plan a motor movement. So the direct pathway, and you know that the basal ganglia, or the better term used would be the basal nuclei, actually composed of the caudate nuclei, the putamen, the globus pallidus, which had the globus pallidus externa and the interna. You had the thalamus, substantia nigra was there, subthalamus was there. All this was components of the basal nuclei or the basal ganglia. So what was the direct pathway? A direct pathway comprised of, I think I'll just go to the figure. Yeah, this was a direct pathway where you had what is marked in red are the neurons which released, or the neurotransmitter released at the tip of the red marked neurons were glutamine, and the blue color neurons are the GABAergic neurons, which released the inhibitory neurotransmitter GABA, or the S substance. So this is a direct pathway of the basal ganglia. We had studied both the direct pathway and the indirect pathway. So you can see that the direct pathway, the glutaminergic neurons which arise from the cerebral cortex ended on putamen, and you called it the corticostriatal pathway, which released glutamine. So when this excitatory neurotransmitter glutamine, it acted on the the pallidum pathway, where you can see that the neurons ending at the globus pallidus internus, which released GABA as the neurotransmitter, which is an inhibitory neurotransmitter. So you can see that the next set of neurons arising from globus pallidus internum to the thalamus, you can see it marked in the dotted line. So what happens is, when the activity, the red fibers from the cerebral cortex which ended in the putamen, which released glutamine, which is an excitatory neurotransmitter, it will increase the activity of the blue fiber, the neuron, which is starting from the putamen, and it ended on the globus pallidus internum. So when the activity in the the pallidal neurons is increased, what happens is, at the tip here, at the internal pallidum, when more of GABA is released, what happens is, since GABA is an inhibitory neurotransmitter, it will reduce the activity of the neuron which is arising from the internal pallidum, which supplies the thalamus. And that particular neuron which arises from the internal pallidum and supplies the thalamus also releases GABA. It's a GABAergic neuron. So, but since the activity in that particular neuron is being reduced, what happens is, at the thalamus, it releases less amount of GABA, and the thalamocortical fibers, which you see as the red fiber which goes from the thalamus up to the cortex, it escapes the inhibitory influence of the pallidal thalamo pathway. So this is basically the direct pathway. So yeah, that's it here. I think this figure can explain you. I think the same thing is mentioned here, the cerebral cortex, which I think I need not explain this figure, we've already done it yesterday. So that's about the summary of actions of the GPI. That's for you all to understand better. Now please have a look at the indirect pathway of the basal ganglia. So what the difference here is, see, please remember, whenever I am using the term corpus striatum, by the term corpus striatum I am referring to caudate, putamen and globus pallidus, and globus pallidus includes globus pallidus externa and the globus pallidus interna. But when I am using the term only the striatum, then I am referring to the caudate and the putamen put together, just striatum, or it's also called as a neostriatum. So the first set of red fibers which is arising from the cerebral cortex and it's ending on the putamen, we call it as the cortico striatal fibers, which actually releases the excitatory neurotransmitter glutamine. This glutamine will I think before I talk about the neurotransmitter, I think I'll just mention the how the fibers go. So you have the red fibers. So please keep in mind that the red fibers, the red color is drawn when the particular neuron releases the neurotransmitter glutamine. So the blue neuron or the fiber is shown where the neurotransmitter is GABA or S substance, which is an inhibitory neurotransmitter. Wherever the line is dotted, it shows that there is an inhibition which is happening in that particular pathway. So the indirect pathway, fibers from the cerebral cortex, the first set of fibers are reaching putamen, or you call it a striatum, which includes caudate also. Now from the putamen, the second set of fibers, see the direct pathway, if you can recollect, from the putamen, fibers directly ended on globus pallidus internal. But here you can see globus pallidus, putamen is connected to the globus pallidus internal, but it's not with a direct fiber. So what's happening here is from putamen or from the striatum, the small set of fiber which arises, it ends on the globus pallidus externa. From there, from globus pallidus externa, fibers arising supplies the subthalamic nuclei. Then from subthalamus, the fibers which arises reaches the globus pallidus interna. Then it's the same as the direct pathway. From the globus pallidus interna, GABAergic neurons supplying the thalamus, and from thalamus it supplies the cortex. So now let's talk about the activity which is happening in the indirect pathway. When the cortico-striatal pathway, I am talking about the first line, the cortico-striatal pathway, glutamine is the neurotransmitter. So when where the fiber, the red fiber ends at the putamen or the striatum, which releases glutamine, which is excitatory, what happens is it will excite or bring about a stimulatory action in the striatal globus pallidum externa fibers, the second set of fibers. So what happens is at the external pallidum, there is lots of GABA which is released, which is an inhibitory neurotransmitter. So what happens is when GABA is released at the external pallidum, this GABA will inhibit the activity or neuronal transmission in the neuron which is supplying the subthalamic nuclei. So that's why there is a dotted line there. So now this globus pallidus external subthalamic fiber is also a GABA releasing fiber. So what happens is when that particular fiber is getting inhibited, the GABA, the inhibitory neurotransmitter released at the subthalamic nuclei is less. So what happens is there is more stimulatory impulse traveling through the subthalamo-globus pallidus internal fiber. So at the point on the globus pallidus interna where the fibers coming from the subthalamic nuclei ends, there is a lot of glutamine which is being released, which will cause a stimulatory influence on the fibers, which is extending from the globus pallidus internum to the thalamus. So at the thalamus, the blue fiber is releasing a lot of GABA, which is an inhibitory neurotransmitter. Then what happens is, you can see that the thalamocortical fiber becomes a dotted line, because when GABA is released at the thalamus, this inhibitory neurotransmitter GABA will start inhibiting the activity of the thalamocortical fiber. So that's about the indirect pathway. So please understand that to initiate and plan a motor movement, you need to have both this direct pathway and the indirect pathway happening, and both these pathways operate in the exactly opposite way. So I think basically today we need to, once we have recollected the direct pathway of the basal ganglia and the indirect pathway of the basal ganglia, we need to know about dopamine, or what we have still pending to discuss is the substantia nigra, a fiber, the pathway which connects the substantia nigra pars compacta to the striatum. So the substantia nigra striatal pathway which releases dopamine needs to be discussed here. I think I'll just go back to this particular figure, which can give you all a better understanding. In this figure, you can actually see both the direct and the indirect pathway. So please try to follow this figure so that I can explain you all so in a better way about the substantia nigra striatal pathway. What is it doing on this? What is the influence of dopamine which is happening here? Please listen to this very carefully, because to understand Parkinsonism, understanding of the substantia nigra striatal pathway is very important. So let's see where the direct pathway works here. So direct pathway of the basal ganglia is, you have fibers arising from the cerebral cortex which supplies the striatum. What is striatum? The caudate nucleus and the putamen nucleus put together. From there, fibers arises which supplies, I am talking about the direct pathway. So that means direct pathway means fibers arising from the striatum, caudate. The orange color one is actually the striatum, which includes the caudate and the putamen. The fibers ends in the globus pallidus internal segment. Now from the globus pallidus internal segment, fibers reach the anterior and the lateral complex of the thalamus, and from there, from the thalamus, the fibers reach the frontal cortex. That is basically the direct pathway. So now let's see the indirect pathway. Indirect pathway is cerebral cortex, the cortico striatal pathway, that is the fibers coming from the cerebral cortex to the caudate and putamen, which is called together as a neostriatum or the striatum. Then what happens is, the fibers coming from the caudate and the putamen or the striatum, small fibers reaches the globus pallidus external segment. From there, fibers reach the subthalamic nuclei. From the subthalamic nuclei, the fibers reaches the globus pallidus. From globus pallidus, it reaches the thalamus, and from thalamus to the thalamocortical connections. So wherever a plus is put, please understand that that particular stretch of neuron, the neurotransmitter is glutamine, and wherever this minus sign is put, please read it as the neurotransmitter there is GABA, which is an inhibitory neurotransmitter. Now our concern here is about dopamine, or about the substantia nigral striatal pathway. Please have a look here. You can see the substantia nigra. Substantia nigra has got two parts. the anterior part and the posterior part. Now, so you have the substantia nigra. The posterior part has got a little dense grey matter, which you call as the substantia nigra pars compacta, and the anterior part is not as dense as the posterior part, and we call it as the substantia nigra reticularis. Now, these fibers arising from substantia nigra pars compacta, which are dopaminergic fibers, they actually end on both the direct pathway and the indirect pathway. Exactly where? On the striatum, isn't it? Striatum, or the what is the striatum? The caudate and the putamen put together, isn't it? This orange one. So you can see that both the direct pathway and the indirect pathway, the fibers coming from the cerebral cortex are coming first to the striatum, and from the striatum, for the direct pathway, fibers go directly to globus pallidus internus, and then the indirect pathway, from the striatum, fibers go first to the globus pallidus externus, from there to the subthalamic nuclei, then to the globus pallidus internus, then the thalamus to the cerebral cortex. So, the fibers coming from substantia nigra, which are the dopaminergic fibers, they end on both the direct pathway and the indirect pathway at the striatum. But what the difference here is, in the substantia nigro striatal connection, the neurotransmitter released at both the direct pathway and the indirect pathway is dopamine. But you can see that the receptor for this dopamine released from the substantia nigra striatal pathway, for the direct pathway is the D1 receptor, and on the and on the indirect pathway, this dopamine is going to act through the D2 receptor. So what I mean to tell is, the substantia nigro striatal pathway influences both the direct pathway. See, you all need to seriously understand here, only then the concept is going to be clear. The substantia nigra striatal pathway, you can see they mark their D1 and D2. Okay, it is a dopaminergic pathway. The fibers which are coming from the substantia nigra pars compacta, two sets of fibers, one ending on the direct fiber, one ending on the indirect pathway. The one which is ending on the direct pathway releases dopamine, and this dopamine is going to bind to D1 receptor, which is present on the direct pathway. The second one is the fiber coming from the substantia nigra pars compacta, which is ending on the indirect pathway, releases dopamine there, and this dopamine would bind to D2 receptors on the indirect pathway. What the difference here is, when dopamine binds to the D1 receptor on the direct pathway, it becomes excitatory. When dopamine binds to the D2 receptors on the indirect pathway, the same dopamine becomes inhibitory to the pathway. So when dopamine is released at the end of the substantia nigra striatal pathway, it stimulates the direct pathway and it inhibits the indirect pathway. So that's about the, now let's go a little more in detail. Yeah, dopamine. So, whatever I have told, I think is mentioned in this slide. I need not. So let's see the last sentence mentioned there. The net effect via the two pathways. So I told you it is it is stimulatory to the direct pathway, the dopamine released, and it's inhibitory to the indirect pathway. So the net effect is there is decrease in the inhibitory outflow of the basal ganglia. That means the dopaminergic pathway, this nigrostriatal pathway is basically limiting the inhibition which is released by the basal ganglia. Now let's go to the disorders of, I think this may require a little more explanation for you all. or I think might be, with another figure, I think I would do it. I think basal ganglia, by today I would actually finish basal ganglia, but I may take one more class for you all, one single class on basal ganglia, where I would really want to with few diagrams, or I would make a flow chart and come to you all might be for another 15-20 minute class, because basal ganglia is not actually a very easy topic to understand. So I'm pretty sure that with these two classes of basal ganglia, I don't expect that you all would have had 100% understanding of the topic, but I'm sure that you listen to the class 2-3 times, at least a 50% is understood. And I think the next class, I don't know when, might be next week or something, I'll make few mind maps and come to you all, so that there's a proper 100% better understanding of the topic. So please need not worry if you find this topic really tough even at the end of the class. Hopefully next week, with a few mind maps, I would make the concept a little more clear for you all. So please try to have 50-60% understanding through these two classes. So that's about the direct pathway, indirect pathway of the basal ganglia, the nucleus, the nuclear groups of the basal ganglia. So now let's discuss the disorders of basal ganglia. Now the disorders of basal ganglia, you can have hypokinetic disorders where the muscle activity movement is less, and also hyperkinetic disorders. Now these hypokinetic disorders are characterized by very poor sluggish movements. There is increased rigidity of the muscle, and this normally occurs in lesions of globus pallidus and the substantia nigra. Please keep in mind, whenever there is a lesion of substantia nigra or the globus pallidus, then the disorder, you call it as the hypokinetic disorder, where the movements are less and there is muscular rigidity. A very typical example here is Parkinsonism. Now for hyperkinetic disorders, it will be characterized by very abnormal movements which will be very spontaneous, and it normally occurs when there is a lesion with the caudate nucleus or the putamen. So now what do you call this caudate nucleus and putamen together? So it's striatum. Example is chorea and ethitosis. Now let's go a little detail into Parkinson's disease. Parkinson's disease is basically the second commonest degenerative disease of the nervous system, and it was discovered by James Parkinson in 1817. And the characters of Parkinsonism are, Parkinsonism is a hypokinetic disorder where the lesion is with the substantia nigra or the globus pallidus. Now what are the characters? In Parkinsonism, you can see tremors at rest, slowness of movement, both the neck and the extremities are rigid, minimal facial expressions. The person moves, basically with Parkinsonism, there is a lot of difficulty with initiation and planning of movement. The person won't be able to start to make a movement. So if he delays, starts to walk, I'm just giving an example of a movement, but he takes very short steps, he'll have a very typical stoop posture. There is paucity associated movements like swinging of hands and dementia is also a feature of Parkinson's disease. Now you have something called as idiopathic Parkinson's disease, which is caused by the loss of the nigrostriatal dopaminergic neurons. What do you mean by nigrostriatal? Already I have discussed, there is a set of neurons, dopaminergic neurons, which arises from the substantia nigra, and it supplies the striatum. What is striatum? The caudate and the putamen put together. When there is a damage there, what happens is there won't be any dopamine released at the D1 and the D2 receptor. So that's idiopathic Parkinson's disease. And in majority of the cases of Parkinson's disease are sporadic, or there's no definite cause. That's what you mean by the term sporadic. Sometimes mutation of certain genes Also you can see Parkinsonism happening, but that's a very rare condition. And this picture shows, how the basal ganglia, or that part of the brain is during Parkinson's disease, and without Parkinson's, how it looks. Just for a better understanding for you all. Now, when there is activation of the nigrostriatal pathway, it's opposite but synergistic effect. Now, when there is activation of the nigrostriatal pathway, it increases the responsiveness of the direct pathway to the corticostriate input, or that's called as the D1 effect. Now, when the responsiveness of the indirect pathway, which is D2 effect, it will decrease the inhibitory outflow of the basal ganglia, and it increases the excitability of the upper motor neuron. Now, that's what happens normally, the D1, D2 mechanism. I have told you how it happens. When dopamine goes and binds to D1 receptor, it's excitatory. When dopamine goes and binds to the D2 receptor, it is inhibitory. That's exactly what is mentioned in proper terms in the beginning 3 points. But what happens is, when this pathway is destroyed, which happens in Parkinsonism, the inhibitory outflow is increased. Timely activation of the motor cortex by the thalamus will be absent when the nigrostriatal pathway gets damaged. So, this is what happens. The substantia nigra, pars compacta, the fibers, D1, D2. D1 is excitatory, D2 you can see a minus sign. So, there is a damage there. So, what happens is, when D1 when there is no dopamine released, what happens is, the striatum or the caudate putamen combination would lose its stimulation, isn't it? And when there is no dopamine at D2, the inhibition on the indirect pathway is lost. So, simultaneously changes would happen in the pathway. See, so in Parkinson's disease, which is a hypokinetic disorder, you can see that there is a cut at the substantia nigra, the striatal pathway. You can see that the D1, D2 pathway is marked as dotted lines. It gets degenerated. So, the direct pathway loses its stimulation, which was coming through D1, and the indirect pathway loses its inhibition, isn't it? So, there is more of activity in the indirect pathway, and there is it just reverses there. So, that is where the Parkinson's disease or the hypokinetic disorder. Now, the most of the symptoms of the Parkinson's disease, this hypokinetic movement disorder, is basically due to the failure of the disinhibition, which is normally mediated by the basal ganglia. So, in Parkinsonism, or when the nigrostriatal pathway is damaged, there is difficulty to initiate any kinds of movements, and if initiated, there is difficult to terminate. For example, when a person with Parkinsonism is not, he would want to make a movement. For example, he would want to walk, but he is not able to start walking. So, what happens is, okay, he takes a lot of time, the planning and the initiation of the movement, which is a function of the basal ganglia, through the direct and the indirect pathway. When there is a damage there, he is not able to plan or begin a movement. He may do it, but he may take a long time to start walking or start a movement. But in case you just try to give him a push, because you are trying to give a push and initiate a movement, what happens is, he would start walking, but then what happens is, he finds it so difficult to put a stop to walking. So, that is what we refer to as, he finds it difficult to terminate that particular movement which has got initiated. Now, so basically the destruction of the nigrostriatal pathway will increase the discharge rate of the inhibitory cells in the substantia nigra, pars reticulata. Increase in the tonic inhibition basically reduces the excitability of the upper motor neurons in the superior colliculus. The frequency and the amplitude of the saccades is reduced. Now Parkinsonism, it's also known as paralysis agitans or also the shaking palsy, because there is tremor at rest. So tremor is there, which is unilateral rhythmic resting tremor. You need to very specifically tell what kind of tremor is associated with Parkinsonism. Rigidity is there. Involuntary increase in the muscle tone present throughout the range of movements. Echinacea or bradykinesia is there, where there is a reduction in the speed and amplitude of any voluntary movement which the patient is trying to execute. There is postural instability also, because the initiation of planning of any motor movement, cerebral cortex is able to do. The planning initiation is with the help of basal ganglia and cerebellum. Now the tremors with Parkinsonism, it is resting tremors, 4 to 6 oscillations per second. Another very significant feature with the fingers, there's something like a pill rolling movement of the thumb and the forefinger. That movement keeps on happening, and you can see that the tremor subsides on voluntary movement. Whenever the person tries to do a movement, the tremor comes down. So that's why we call it as the tremor of Parkinsonism is the resting tremor, and the tremors increases in any emotional outbreak. Can you see? You can see that's a pill rolling movement which is happening there. One second, that's a little problem with the movement of the slide. Sorry, I'm just not able to move the slide. I'm just pausing for a second. So you have the next one, rigidity, which is a major feature of Parkinson's disease. Now, if for Parkinsonism, there can be two kinds of rigidity. You have the cogwheel rigidity and also the lead pipe type. Now, the cogwheel rigidity is when when the limb is passively flexed or extended, there is a resistance which is felt in jerk. When you try to passively flex or extend the arm, a resistance is felt, but it will be felt in a jerky way. Now, yeah, can you see? Yeah, this is a cogwheel rigidity. Either flexion or extension, resistance is there, but with jerks. Can you see? Exactly, the cogwheel rigidity is being demonstrated here. Now, when there are no tremors, the rigidity seen is the lead pipe type. The rigidity felt during flexion or extension is uniform as the what you saw now is the cogwheel rigidity. The second type of rigidity is a lead pipe type, and in the lead pipe type, either during flexion or extension, the rigidity felt would be uniform, as just like a bending of the lead pipe. Yeah, so you can see the smooth and consisting the lead pipe rigidity, and then you have the ratchet like the cog wheel type of rigidity, where the flexion or extension is happening at different stage with the jerky movement. Now the next is bradykinesia or echinacea. You use this term when the motor movements are basically slow and stiff, and this happens when basically most of the small distal muscles are affected. This is also manifested as when there is a loss of facial expressions. You call it as hypomimia. There is mask like face. There is absolutely no any expressions on the face. Hypophonia is there, where the person starts speaking very softly. Now there is slowness of walking, and see, normally when you walk, there is swinging of the arms, but with this, there is no associated swinging of the, even when the person walks taking very short steps, his hands doesn't swing along with the leg, which normally happens. Hands just, stands rigid on the two sides of the body. Even when there is slowness in dressing, slowness in turning in the bed, even to look at an object, what happens is instead of turning the neck, the patient turns the whole body. So this is hypomimia, and the person in picture is Muhammad Ali, the boxer. So you can see him in action in his young age. Now here in the second pic you can see same Muhammad where you can see hypomimia, or there is absolutely no expression on the face. And all this, please remember to initiate movement, facial expression, any kind of movements. You have the indirect pathway and the basal indirect pathway and the direct pathway of the basal ganglia, which needs to operate properly. Here, because of a damage in the substantia nigra striatal pathway, that pathway is not working properly. So that's why all these disorders or defects are being seen. So you can see the finger tapping, micrographia, all these are features. Postural instability is there, stooped posture. There's no arm swinging when the person is walking, small shuffling, short step, freezing, all these are features. Now let's see the last one, the hyperkinetic disorder, which you also call as the Huntington's disease. Now this is one of the most common inherited neurological disorder, and it was discovered in 1872 by George Huntington. Now the Huntington disease is characterized by very gradual onset of defects in a person's behavior, cognition and movement. And Huntington disease normally starts in the 4th and the 5th decades of life. That means when the person is in his 40s or 50s. And it's basically a progressive disorder which results in death. Huntington disease is an inherited autosomal dominant trait. The person's irritability is increased, he becomes suspicious, and there is a kind of eccentric behavior. Now the hallmark of the disease is movement disorder. All those other features are there, like increases irritability, suspiciousness, eccentric behavior, but the hallmark of the disease are the disorders affected with the movement, because any disease associated with the basal ganglia or the cerebellum would be reflected on the movements. Now what are the defective movements which you see in Huntington disease? You have rapid jerky motions with no clear purpose. That's what you call as chorea, or chorea is the movement of a person is kind like a dance, so we call it as a dance movement. It's confined to a finger or the whole extremity. It can be you can see the facial musculature getting affected, or even the vocal apparatus can get affected by the Huntington's disorder. There's no weakness, ataxia or any deficit with any of the sensory functions of the body. Movements are involuntary. Now patients incorporate them into deliberate actions. So now this is a neuropathology. There is selective atrophy of the caudate and the putamen. That means the striatum is getting damaged here. Can't you see the Huntington? The first figure shows the patient's brain with suffering from Huntington disease, where there's atrophy of the caudate and the putamen or the striatum, and you can see a normal person's caudate and putamen with the section. Now it's associated with degeneration of the frontal and the temporal cortex. The medium spiny neurons that project into the globus pallidus externus is actually degenerating in the Huntington's disorder. Now here in this disease, what happens is the globus pallidus externus gets overexcited. Now when the GPE, globus pallidus externus, if you are able to recollect, it was lying just next in between the putamen and the globus pallidus internus. So when the GPE gets overexcited, it reduces the excitatory output of the subthalamic nuclei to the globus pallidus internus. Inhibitory outflow of the basal ganglia is getting reduced. The thalamic nuclear group is activated, and it in turn activates the motor cortex. And what motor cortex, when it gets this extra stimulus, what it does is, it is activated by so many undesirable signals. It is getting unnecessarily stimulated, which is resulting in this undesired ballistic and the coriform movements. That's why the movements become like a dance, because of this extra stimulation with the cerebral cortex is receiving. Now, the treatment, basically there is no definite treatment of the Huntington's chorea, and disease, it's called as, it's progressively fatal. So, you have the picture here. So, in Huntington's disease, the fibers which is arising from the striatum, that is, the caudate putamen is the striatum, which is supplying the globus pallidus externus, is getting degenerated. So, so you can tell that the disease occurs due to degeneration of the GABAergic striatonigral pathway. GABAergic and cholinergic neurons are lost in the striatum. That's, to brief up. Now, you have the last one, which is Hemiballismus. Now, this ballism is basically defined as involuntary movements that are flailing, intense, or the movements which are very violent in nature. Usually it occurs all of a sudden, and ballism occurs when the subthalamic nuclei gets damaged. Hemiballism is common than ballism, and hemiballism occurs due to hemorrhage in the subthalamic nucleus of the opposite side of the brain. So, I think that's it, and ethitosis and chorea is already done. So, there we come to an end of basal ganglia. So, as I promised, might be after sometime next week, I would do a small class on basal ganglia, where I would like to brief up all the circuits with the disorders of basal ganglia, Parkinsonism, Huntington's disorder, Hemiballismus, everything through mind map, and I hope that the whole chapter of basal ganglia would be in and out thorough for you all. Please be thorough with basal ganglia, because basal ganglia, or the basal nucleus, is a very, very often asked university 10 marker for you all. So, thanks for listening, guys. Study well.